Okay, welcome to our first webinar session on equity in the eCOVID19 RecMap. For today's session, we have two presentations, one with our colleague Omar who will talk to us about eCOVID19 guidelines. So COVID-19 guidelines on the RecMap and equity. And our colleague Ashley Mutilal will follow that with a presentation on our plain language recommendation work and how we considered equity through that. So everyone is going to be automatically muted. This webinar will be recorded. If you have any questions for our presenters, please drop them in the chat box, or also you can wait until the end of each presenter's presentation. Otherwise, we can start. And Omar, we can start with you.
Excellent. Okay, can you see my screen? Yep, excellent. Okay, so hello everyone. My name is Omar Duidar. I am a research associate at the Bria Research Institute based in Ottawa, Canada. I'm also a member of the Cochrane Equity Methods Group and the Grade Equity Working Group. And today I'm going to be talking to you about equity in the eCOVID RecMap. So in my topic today, I'm going to cover four main things. So first, I'm going to cover about what are health inequities and how are they identified. Second, I will talk about the importance of considering equity in guideline development. And third, I will share with you how we applied an equity lens to the development of the eCOVID RecMap. And then fourth, I will share with you our ongoing evaluation of equity considerations using the recommendations presented on the map. So before we start, I think it's really important to differentiate between two terms that are commonly confused but are not interchangeable. So the terms inequalities and inequities. So according to the WHO, inequalities are differences in health status or in the distribution of health determinants between different population groups. Now, initially, this was the term used to describe unbalanced conditions. But the problem with that term, inequalities, is that it does not account for whether the difference is avoidable or not. For example, unavoidable differences would be sex or genetic differences. In contrast, the term inequities includes a social justice lens. So we are not just looking at whether there are differences in health outcomes, but we also include a moral judgment of whether the difference is potentially avoidable or not. Even if they're avoidable, are they acceptable? Like, for example, the increased risk of poor health outcomes when you engage in extreme sports, or are they unacceptable? Like, for example, the increased risk of TB infection in the Indigenous populations of Canada versus the rest of the Canadian population. But it's also important to understand that health inequities are not just caused by poverty and low income. There are several factors that could contribute to our population being socially disadvantaged. One of them could be place of residence. So for example, rural areas have lower access to healthcare because of lower numbers of family physicians in these areas. Another one would be race or ethnicity. So for an example would be in India, children from certain castes are less likely to be immunized than others. Occupation could be a reason. So workers of certain occupations are at higher risk of occupational related injury or death, for example, just like coal miners, or in the case of COVID, healthcare workers. Gender or sex could also be a reason. So for example, in many cultures, having a son is preferable to a daughter. And we've seen high rates of infanticide of baby girls and neglect, and also sex selective abortions. Religion could also be a reason. So for example, in Amish populations have lower immunization rates compared to other populations, which lead to a lot of outbreaks and diseases. Education as well. So lower maternal and paternal education is associated with reduced rates of breastfeeding. And then of course, the one that we always think about, which is socioeconomic status. So in areas where there is like a high incidence of malaria, individuals with low household wealth are less likely to own bed nets and are in turn at greater risk of infection. And then one other one is called social capital. And that's something that really not a lot of people think about. So socially isolated people are 2 to 3 times higher, have higher death rates than those with a social network and social sources of support. And when you put all these factors together, we form this acronym called PROGRESS, which is a framework that we commonly use as a memoir to identify populations experiencing inequities. There's also an additional component to PROGRESS, and it's called PLUS. And this PLUS allows us to consider additional context-specific factors that are generally categorized into 3 things. So the first one, personal characteristics that attract discrimination, such as age, disability, or sexual orientation. Second one, +2, features of relationships that lead to health inequities, such as smoking, parents, exclusion from school, other social hierarchies. And the third one would be time-dependent relationships, such as leaving hospital, respite care, or prison, or other instances where an individual might be temporarily disadvantaged. So guidelines have a role in reducing inequities by explicit considerations of the impact of individual, patient, or policymaker decisions on health equity. So reflecting the potential of guidelines to influence health equity, the WHO has included a chapter on equity, human rights, and gender in their guideline development handbook. And also GRADE mandates guideline developers to make a judgment on the impact on health equity in their ETD frameworks. Similarly, again, NICE also acknowledged that health equity is important to consider in guideline development and have identified age, ethnicity, and gender as protected characteristics that must be considered under UK equalities legislation. And they also acknowledge that other equity issues might be considered depending on the guideline. And similarly, in other organizations as well, they've mandated this focus on equity. But equity could come in the guideline, can be considered in the guideline in 2 forms. So it could be a major focus or it could be a minor focus. So a major focus would involve developing a guideline focused on populations experiencing inequities. And in that case, an equity lens would have been used throughout the whole guideline. And an example of that would be homeless guidelines. So the population that they're addressing here are individuals that are suffering from living instability and homelessness, which are disadvantaged, across the board. Another form would be the minor, as I said, and in that case, there would be certain questions that are considered equity sensitive. So they're basically populations that they're addressing are likely to experience inequities. And an example of that would be guidelines on maternal health, where you might find a couple of recommendations focused on women with low income or low education level. So to facilitate better integration of equity in guidelines, in 2017, the GRADE Equity Working Group published a series of 4 papers detailing how to consider equity in several aspects of the guideline and recommendation development. So in paper 1, they introduce this concept of equity sensitive questions, which I just mentioned. And that's when the population of the PICO question is addressing population experiencing inequities and answer these questions. And in that case, consideration of equity is necessary. Paper 2 highlights 9 topics of the GINMAC master checklist where equity could be relevant, starting from setting priorities. So for example, in the case of with the equity lens, the guideline development group should prioritize equity sensitive questions in guideline group membership. So diversity should be there and proper representation across the board from low middle income countries, high income countries, and as well individuals with lived experience. And when it comes to identifying the target audience, they should involve users representing these disadvantaged populations or populations experiencing inequities. And when it comes to generating the PICO questions, they should develop questions that capture equity issues at hand. As well, when it comes to considering importance of outcomes and interventions, they should also consider if there are any differences in values and outcomes across different population groups and attend to that accordingly. And deciding what evidence to include and searching for the evidence itself, they should search literature relevant to disadvantage, and I'll have an example of that moving on. Number 7, summarizing the evidence. So whenever they're developing the recommendation, they should consider judgments for, equity, acceptability, and feasibility, and provide that information. Wording of recommendations, making the actual state recommendations or actionable statements accessible to disadvantaged in terms of understanding and literature level. And finally, evaluation and use, so facilitate the implementation and use among disadvantaged. So paper 3 discusses 5 approaches to consider equity in rating the certainty of evidence. And that could be considering equity as an outcome, or considering patient important outcomes, or also creating separate summary of findings tables due to differences in relative effects, displaying baseline risk and absolute events for populations experiencing inequities, and finally, assessing directness of evidence to these populations. The final paper of the series discusses the importance of equity when going from evidence to decision. So although the GRADE ETD framework involves making a judgment on potential impact on health equity, this paper argues that equity would be relevant in all the criteria and could be considered systematically throughout when judgment for equity criterion is challenging. So as you all know, the COVID-19 pandemic has disproportionately affected racialized and marginalized communities, exacerbating existing inequities and creating new ones as well. So for example, older adults living in socially deprived urban neighborhoods are inherently at a higher risk of social isolation and loneliness. So under social isolation guidelines, older adults living in socioeconomically deprived urban neighborhoods experience this sort of double lockdown as a result of spatial inequities associated with COVID-19. So these differences in impact in part reflect underlying structural, societal, and economic problems that have increased the risk of community exposure. And with several countries recognizing that and putting health equity at the forefront of the public health response, guideline recommendations should have been developed that way as well. And that's why since the beginning of the pandemic, a research team at McMaster and Cochrane, Canada, have been leading the development of a living catalog of COVID-19 recommendations in collaboration with several other organizations in Canada internationally. And the purpose of this map was to provide access to information to facilitate evidence-informed decisions. And one of the key features of this platform is that it provides a gateway to allow users to decide whether to adopt the available recommendation as it is, adapt it, or create de novo recommendations. But one of the key things that we had in mind when developing this was to apply an equity lens. So equity was a central theme and in how we developed the map and also how we managed it. So as you may recall, these are the 9 Gin McMaster topics where the GRADE Equity Working Group identified equity to be relevant. And you can see here that at setting priorities, we had engaged stakeholders in priority setting to basically make sure that the work that we are producing on the map meets the needs of our knowledge users. And when capturing the PICO questions from the guidelines, we used Progress Plus framework, which I previously described, to identify recommendations focused on populations experiencing inequities as we were extracting the statements from the guidelines and adding them to the map. Then when we searched for the evidence, we looked for guidelines in several languages, including Chinese, which had the earliest evidence related to COVID-19 and its impact on high-risk populations. And for summarizing the evidence, we collected all the information from published evidence to decision frameworks related to equity across all the ETD criteria. And when it came to the wording of recommendations, we set up a structured multi-stakeholder process to take recommendations from the guidelines and transform them into what we call plain language recommendations that enhance the accessibility to COVID-19 health information, which my colleague Ashley will talk about later on. So we also prioritize equity in the presentation of the recommendations on the map. So what you're looking at here is the grid view of the map. On the top are the different topics by which the recommendations fit to. So infection control, vaccination, diagnosis. And on the left, you have the populations which these recommendations are addressing. And what we set up this filter here on the right, so the knowledge user could help focus their search on whatever's relevant to them. And we installed a equity filter defined by the Progress Plus characteristics. So you can use this filter to identify recommendations focused on, let's say, women, if you click on gender or sex, or people living in rural and urban setting for place of residence. And similarly, you can look for recommendations on older adults for personal characteristics. So at the recommendation level, we also presented the judgments for equity in the ETD frameworks, and also any research evidence used to support the judgments on the map. So you can see here, this is a recommendation on the BIVP vaccine for people aged 60 years and older. So we captured the judgment for equity, so increased impact on health equity, and also evidence related to its implementation in different settings. So all these efforts have facilitated a conduct of equity assessment of COVID-19 actionable statements. So when we say actionable statements, we mean two things. So the first one is the formal recommendations, which result from a systematic process and are appropriate for formal rating of evidence. And those are the traditional recommendations. And the second would be good practice statements, which are statements that are that the benefits clearly outweigh the harms, but are not appropriate for formal rating. And for our study that we're conducting right now, we had two objectives. So first of all, identify equity-sensitive COVID-19 recommendations and good practice statements, and two, describe how equity was assessed in the development of those formal recommendations. So we retrieved all the formal recommendations and good practice statements uploaded on the living map as of July 27th of this year. And the details are all on the MAP website if you're interested. And then we use that Progress Plus framework that we had employed in the extraction of the recommendations to basically identify recommendations focused on populations experiencing inequities. An additional thing that we did in the process was recategorize Plus. So as I mentioned, Plus is grouped into three groups, and those are very broad. So we kind of created subcategories iteratively as we identified them. And then finally, to assess how equity was considered, we used the GRADE equity working group guidance to classify how equity evidence was used in the certainty of evidence and also in the impact on health equity criteria in the ETD. So in this figure, we're looking at the distribution of recommendations and good practice statements across the Progress Plus factors. So of the 758 formal recommendations on the map, 120 were focused on populations experiencing inequities, so equity sensitive, and those are the bars here in red. So over 40% of them were focused on children, and 17% were focused on pregnant women, and 13% addressed breastfeeding mothers. As for the GPS, 21% were equity sensitive, and similarly, again, focused on children, but they addressed a bit more, people working in high-risk occupations like healthcare workers and immunosuppressed individuals. So when we wanted to assess how equity was considered in the evidence to decision criteria, we only found 87 out of the 120 recommendations accompanied with an ETD framework. So of those, 53 assessed indirectness of the evidence to populations experiencing inequities. And what was really interesting was that the majority of them had reduced the certainty of evidence for that reason. So one recommendation considered relative importance of patient outcomes for populations experiencing inequities, but none assessed differences in magnitude of effect, and two considered differences in baseline risk. When we looked at equity considerations in the impact on health equity criterion, we found that the majority of the considerations were in the form of implementation considerations, but rarely in the form of differences in relative effectiveness or baseline risk. So in summary, there are three main findings. The first one is that 18% of recommendations and good practice statements are focused on populations at risk of inequities. 57% of recommendations with ETDs reported reducing certainty of evidence due to indirectness to populations, a risk of inequities, and 18% of recommendations with ETDs assessed equity and the impact on health equity criteria, and most frequently as implementation considerations. So this assessment really shows that very few recommendations were actually developed considering equity issues, but maybe the guideline developers considered equity in other ETD criteria. And since we already captured that, so we could really go and look into the acceptability, feasibility, and cost and resources criteria. The other thing that we really want to check is, was the reduction in the certainty of evidence appropriate? Because the grade working group had cautioned against reducing the certainty of evidence for indirectness for population differences unless there is a compelling reason to anticipate differences in effect. And that could be due to biology, sociocultural influences, or setting-specific resource issues that could impact the effectiveness or harm. So reducing inequities would itself, and reducing the certainty would in itself increase inequities, and that would lead to less of a use of an effective intervention for populations experiencing inequities. Another thing that we would want to do is see how equity was considered in the development of these guidelines as a whole, because maybe they used an equity lens that could have prompted these considerations that we see, or maybe lack of. But what did this mean for the RecMap? So first of all, from this work, we were able to identify equity-sensitive recommendations that were developed with equity considerations in mind. So we can highlight those on the map and make sure that they are more accessible for our knowledge users. And the second thing, the plus categories identified from our work can be used to reclassify that filter on the RecMap to make it something more meaningful for our users, instead of using the standard categories +1, 2, and 3. And that brings me to the end of my presentation. Thank you very much for listening.
Thank you, Omar. Great presentation, great lens. Let's see if we have any questions for Omar before we move to our next presentation. I know I learned a lot. Any questions or feedback? All right. So we move on to the next presentation with our colleague Ashley on plain language recommendations and the RecMap. To you, Ashley.
Thanks so much,
Omar.
Nora. Okay. All right. Hi, everybody. Thanks for having me today. My name's Ashley, and I'm a research coordinator at McMaster University. I'm leading the plain language recommendations component and knowledge mobilizations component. And today I'll take you through these two things. And hopefully by the end of this presentation, you'll see how equity ties into these two projects. So over the course of the pandemic, we've seen a large increase in COVID-19 recommendations, which have been projected through different sources. And this meant that the average person needed to make decisions about their own health, but they were faced with lots of information and dealing with complex terminology. And the questions that they had through the pandemic were, how can I protect myself against COVID-19? What are the treatment options for COVID-19? And should I get the Pfizer vaccine? So it was definitely critical to make these recommendations more understandable and more accessible for a public audience, and to ensure that we're not excluding anybody with our language. And so that's why we've developed the plain language recommendation, which by definition is an easy to read summary of up-to-date published quality checked recommendations from guideline development organizations. It's an unbiased statement that includes a description of the recommendation, how it applies to the patient and the public, and also includes a link to the recommendation source. And it's also digitally accessible for everybody, including patients, caregivers, and the public. And the plain language translation of these recommendations can enable the public to better understand and learn about their own healthcare options, as well as create a more meaningful patient-physician relationship. And we do currently have 56 COVID-19 PLRs available on our RecMap right now. And our process for developing PLRs are detailed in the Journal of Clinical Epidemiology, but today I'll just give you a snapshot of that process in the next few slides. So first, I just wanted to briefly go over our plain language recommendation and the 10 main components in the PLR. So first, we start off with our clinical question, and this is the question that will be answered in the PLR. Then we have our recommendation statement, that is the original guideline statement translated to plain language. The next is the population, which describes who this recommendation applies to, and also answers the question, what does this have to do with me? We then have a definition of the recommendation strength. So what's a strong recommendation? What's a conditional recommendation? And then we go through explaining why this recommendation is strong and why it is conditional, for instance. And the box next to it is an additional information box, which contains details that may be important for the reader to know. Following that is our benefits and harms of the intervention, which is just a summary of the benefits and harms. And then you can also explore the benefits and harms by numbers through this interactive summary of findings table. And lastly, these last two boxes are, what does this mean for you? And it explains actions that the population can take, offers very helpful sites, and also helpful topics that you can discuss with a healthcare professional. So next, I'll take you through our process here through this flowchart. So our PLR development process. And one of the first stages in our chain is our multi-stakeholder meetings, in which we have various stakeholders such as clinicians, academics, undergrad students, members of the public, who come together and discuss topics that we should prioritize for PLR development. So for example, booster doses is a good topic. So then afterwards, we pick PLR topics by considering all recommendations on the RecMap and also interest to citizens as judged by 2 large research teams. And once we have our PLR topic, we select an actionable statement from the RecMap. And we have 3 different types of actionable statements to select from: formal recommendations, good practice statements, and additional guidance statements. So once we have selected an actionable statement relating to our priority topic, it then goes through editing. And they're drafted in Google Docs and taken through our trained editing team, first through drafting, then through checking, which is our validation stage, then through citizen editing, which I'd like to highlight because we do work with 3 high school students who are responsible for making the PLR more understandable, and they might ask themselves, are everyday English words used? And does the PLR provide enough information for the public to use this recommendation? We then have medical editing, in which the doctors on our team ensure that the meaning is not lost in the PLR and also make the final decisions regarding its content. And then finally, this is published to the RecMap using the software GradePro. Our editing stage usually takes around 3 to 4 weeks. So we try to upload our PLRs on a weekly basis. And so I just wanted to go through 3 different resources that we provide to our team and maybe also useful to you to improve your language and also make it more inclusive for the public. So the first is the Hemingway editor, and it's an app that analyzes the readability of your sentence. So it picks up if you're using hard to read words, if you're using a passive voice. And then we also have dictionaries and glossaries. So the first is the Plain Language Medical Dictionary from the University of Michigan. And the second is the Get It Glossary, and it allows users to find plain language alternatives to difficult and complex medical and health research terms. We're also in the process of translating our PLRs to different languages to increase the scope of it. And so we are translating to French, Spanish, Italian, German, Arabic, and Portuguese. And we are working with volunteer translators to review a DeepL or Google translated document. And then once they review and edit it, this then goes through GradePro and then is uploaded to the RecMap. And then finally, I wanted to touch on knowledge mobilization, which is the next big step for the eCOVID19 RecMap. And while we noticed that the RecMap existed, we wanted to get it into the hands of the people that needed it the most. So we've included and are working with relevant and diverse knowledge users from low middle income countries to high income countries. And we're working with them to achieve the aim of increasing the awareness, use, and engagement of the COVID-19 RecMap. And some of the activities that these groups will be working on are related to identifying the barriers and the facilitators of using the RecMap with these groups. And this will be used to facilitate the improvement of the RecMap. And we do have a working framework, which I can share with you after the webinar. But that is it from me. It was a short presentation, but yeah, thank you. And I'll open it up for any questions that you may have.
Thank you, Ashley.
Thank you.
Impressive work. Do we have any comments or questions for Ashley? Okay, so maybe I can actually have a question to both you and Omar. In your experience working with the COVID-19 guidelines, do you see any aspects of the work so far, both in addressing equity in COVID-19 guidelines for Omar, and then for PLR development for COVID-19 recommendations? Do you see room for improvements for non-COVID-19 guidelines and recommendations? Do you see the lessons learned as transferable to non-COVID-19 recommendations? And do you have any idea whether non-COVID-19 guidelines would be doing better in terms of equity in comparison to COVID-19 guidelines? Definitely out of scope, but something I was curious about.
Yeah, Tamara, that's a great question, a very loaded one, but I'll try to answer it as much as I can. So room for improvement, I think that was the first thing. I think there's always room for improvement, especially how we know that equity was a very, fundamental thing that we wanted to, pick up during the COVID pandemic. And unfortunately, we knew that we weren't doing a very good job because of the time frame, because not enough resources, and also difficulties in actually knowing how to address equity. But I think from this assessment of the COVID guidelines, we can see that there's a lot of dependence on panel judgments and expert opinions on making judgments for equity. But what I did find really interesting was there wasn't really enough information on why these judgments wanted to support them. Like, even there was a lot of guidelines that had no equity issues identified. It was, how did you get there? Why do you think that? And what are the implications of that? I think that's again really something that we would like to see with non-COVID guidelines. And I can tell from we did an assessment of WHO guidelines published between 2014 and 2019, and that was of course before the pandemic. There was, I think, a lot more details in the ETAD tables, not necessarily I think useful information, but definitely a lot of what the judgment, what the panel had on their mind, and certain judgments that again were evidence-based, some were based on expert opinion or consensus, but definitely way more information than we were seeing in these COVID guidelines. So I do think maybe with the return to the post-pandemic return of things to normal, we will see more information in these ETDs that we could actually use to guide our next steps on what do guideline developers need to make this judgment. Are these judgments appropriate? How can we as methodologists help them? And yeah, is that all your questions? Did I miss one?
That's great. Thank you, Omar.
Okay.
Ashley, any input?
Yeah, no, thanks, Tamara. I think there is room for improvement. And this is sort of my first experience with plain language, especially with COVID-19. There's lots of guidelines out there, but I think it can be applied to non-COVID-19 guidelines, like, for example, tuberculosis. So there's lots of also resources that can help the other diseases to making plain language recommendations. We have the GIN Public Toolkit. We now have this framework. So there's lots of applicability with the plain language recommendations, and it'll definitely be useful for the public.
That's great.
And I would also actually like to add something. So it was really interesting when I was making this presentation, and I kind of just brought up the 9 GIN McMaster topics where equity could be relevant. And I found it very interesting that we had, like equity across so many of those topics. like, I don't know if it was planned. I don't think, like, it was planned to a degree, but it made me feel that I think with upcoming maps, there could be, you know, more considerations across other, you know, topics, because it's like this map is like almost a giant guideline of recommendations that are already published, right? So applying that approach or that guidance to the map or any other map that we work on, I think would be very valuable. And a lot of, again, guidance on, we can also make guidance on how to, you know, apply an equity lens to living maps, not just guidelines.
Wonderful. Thank you, Omar. Thank you, Ashley. This has been a great presentation. I don't see any questions in the chat box. Thank you for our attendees today. If you think of any follow-up question you'd like to discuss with our presenters, please feel free to reach out. You can paste your emails, please, in the chat box, our presenters, Ashley and Omar. Otherwise, the recording will be posted on our YouTube channel, and we will advertise for that on our social media platforms. Thank you for the great information today, and stay tuned for more work with the eCOVID19 RecMap. Thank you.
Thank you all.
Bye.
Bye-bye.